screen just.
Yes, sir. Yes. Just make it. Are they visible, sir?
Yes.
Yes. Okay. Shall we start? Okay. So this is the first OSCE. So as you can see, there is a device which is there in this image, and we have questions pertaining to this device. So I would like to ask, what is this device, and what are the principles it is based upon, and what is the law that governs its functioning? What are the wavelengths of lights which are used in this pulse oximeter, which is a device, and how is it useful in neonatal screening?
Okay.
Okay, so most of you are answering correctly.
Yes.
Uh, so, so the principles which, sorry, just
Okay. So the two principles on which this works is, first is your spectrophotometry. So does anyone knows what is spectrophotometry? So this spectrophotometry is basically based on the Beer-Lambert law. So what is Beer-Lambert law? So basically Beer-Lambert law states that the concentration of any absorbing substance in a solution is directly proportional to the intensity of light transmitted to that solution. What does it mean? So suppose you have something absorbing substance in your solution and you're passing a light. So the intensity of light that is transmitted through the solution is proportional to the concentration of that absorbing substance in that solution. So what happens in pulse oximeter is that you must have seen there are two. In pulse oximeter probe, you must have seen there's one side in which there is a light, red light that is fluctuating, and other side you can see the detector. So this light, what you see is actually there are two lights of two different wavelengths. So first is your the wavelength that is in the red spectrum, that which has a wavelength of like 600 to 750 nanometer, and the other one is the infrared light, which is easily not visible with our naked eyes, but has got a wavelength of like 700 to 1300 nanometer. So normally the oxyhemoglobin has got an affinity with the infrared light, so it absorbs of more of infrared light, and the deoxyhemoglobin absorbs the red wavelength of the light. So this red and infrared are actually projected. So when you apply the pulse oximeter probe, the red and infrared light are actually projected through the skin, and then this got absorption with the hemoglobin and the oxyhemoglobin based upon their concentration, and then the amount of light that is reflected back into the after getting absorbed, the amount of light that is reflected to the photodetector is being absorbed. So based upon the amount of light that is transmitted, it detects the ratio of deoxyhemoglobin to that of oxyhemoglobins. So this is known as spectrophotometry. And what is photoplethysmography? So pulse oximeter basically detects the oxygen saturation in the arterial blood and not in the venous blood or in the capillary blood. So how it is being done? So basically, it measures this absorption characteristics in the pulsatile blood and excludes the measurement in the non-pulsatile blood, which is there in the venous blood and the capillary blood. So photoplethysmogram is the principle behind which it measures the arterial oxygen saturation and not the venous and the capillary oxygen saturation. So this is about the first two questions. So wavelength already discussed. So red is for red for 600 to 750 nanometer, and infrared is for 900 like 700 to 1300 nanometer. So what about neonatal screening? I hope many of you are doing neonatal screening at your center. So how do you do the neonatal screening? This is a very important test to perform neonatal screening, particularly to rule out critical congenital heart diseases. So how it is being done? So the pulse oximeter probe is so basically it is done 24 hours after life, because if you do before 24 hours of age, the chances of false positive rates are too high. So no, normally it is done either after 24 hours of life or just before the discharge. So what you do, you apply the pulse oximeter probe to the right hand and one foot, right? Like the right foot or the left foot, and then you measure the saturation values. So if the pulse oximeter values are below 90% in either right hand or either foot, it is called as a failed pulse oximetry test. It means the baby might be having some cardiac condition or maybe a pulmonary condition. So you have to rule out the cardiac condition by doing a echocardiography. However, if you find that the pulse oximetry reading in the right upper limb and either of the foot is more than equals to 95%, and the difference in the saturation between the right hand and the foot is below 3%, so it will be called as a pass test. Means the chances that the baby is having a critical congenital heart disease is very, very less. However, if we find that if the baby saturation is between 90 to 95% in either right hand or foot, or the difference is like coming more than 4%, so an intermediate value between the fail and the past, you perform a retest in 1 hour, and then based upon the value of the retest, so either if it is a pass, like if the saturation in the right upper limb and the foot is crossing 95% and the difference is less than 3%, it will call it a pass test. Or if it is not there, then call it a failed test, and the baby will go for echocardiography to rule out critical congenital heart disease. So this test has to be done prior to discharge, because it has been shown that if you combine this test along with antenatal ultrasound and the clinical examination, the chances of missing out critical congenital heart disease is very, very less.
So, so next we go to the next question.
Yes.
So next question is basically a 3-day-old, 27-weeker, 980-gram male neonate who was on mechanical ventilation, and he was noted to have tachycardia, increasing FiO2 requirement, and development of feed intolerance. So as usual, we repeated a sepsis screen, but it came out to be negative. So we performed a point of care echocardiography. So the images of which are shown below. So let's just see what are the questions do we have. So first question is, what are the three images which is shown in the previous slide signify? What is the most probable diagnosis? What is the underlying pathophysiology in operation in causing these clinical features of this baby? What are the likely systemic complications are we anticipating in this baby? What are the possible therapeutic options? And then we will discuss the pharmacological therapies. What are the dose, duration, and frequency of the pharmacological agents which are used to manage the above condition? And what is the existing evidence base for the management, and what can be the other eco parameters which can be used for its diagnosis.
Okay, so
So,
many of them.
yes,
Yes, Yusuf, please carry on.
yes. So as you can see, this is a 3-day-old extreme preterm neonate who has tachycardia, increasing FiO2 requirement, and feed intolerance. So most likely, this is somewhat with a sepsis screen negative. This is most likely pointing towards the diagnosis of HSPDA. So these are basically the three images which you can see in this slide. So what is the first image? So first image is basically ductal view. So where you can see the hemodynamically significant duct. The second image here is basically the M mode cursor in the plaques view, and it is measuring the left atria to aortic ratio. And the third image, which is here, is basically we have applied the continuous wave Doppler on the ductal on the PDA, and we are assessing the waveforms. So how do they help us in basically classifying the severity of the PDA, and how do they help us in management? Let's just discuss that.
So
So yes,
Yusuf, just
yes,
a second.
yes.
So can you use this Doppler view to measure the size of the PDA? So Dr. Yusuf has nicely told about those views. So can we use this? Okay, no. Why we can't use? So answer is correct, Dr. Govind and Dr. Monalisa. So why you cannot use this view to measure the size of PDA? Overestimate. Okay. So because there is a scattering of the color, so actually you can overestimate the size of the PDA. And why do we measure the size of the PDA? By the way. Yes, overestimates. If you use this color Doppler to measure the size of PDA, it will overestimate. So where do you measure the size of PDA in this view? Narrowest diameter. Where is the narrowest diameter? Pulmonary end. Okay. So narrow. Yes, it's correct. So we measure the narrowest diameter before it enters the main pulmonary artery. Okay. So this is where we measure the PDA. Isthmus is not there, so we measure the narrowest diameter just before it enters the main pulmonary artery. Okay. So can you explain this, Yusuf, this LO ratio, just of a
Yes,
second?
sir, I'll be discussing in the
Okay, okay,
subsequent
sure, sure,
slides as
sure.
well.
Please go ahead.
Okay, so the most probable diagnosis in this case will be a hemodynamically significant patent ductus arteriosus. So, can anybody tell what is the underlying pathophysiology which contributes to the above clinical features?
Please
How does
write,
it?
write in the chat box. Okay, ductal steel. Ductal steel in which? Where ductal steel? So there is a direction of flow from left to right. Yes, left to right sending. So there will be ductal steel in the systemic circulation, and there will be pulmonary overflow. Yes, correct. So
Oh, correct.
Dr. Gaurav Gautam has given correct answer.
So
Yes.
it is basically pulmonary overcirculation and systemic ductal steel. Very nice. So what are the likely systemic complications do we anticipate in a baby with a hemodynamically significant duct?
Hypertension because of systemic hypoperfusion. NEC. Yes. All end organ dysfunction will be there.
Yes,
Correct.
yes. So that is
ठीक है.
correct.
Hmm.
What are the possible therapeutic options? What are the various pharmacological therapies which is available for managing this condition? And could you please describe the dose, duration, and frequency of these commonly used medication? And what is the most commonly used medication in most of the NICUs these days?
Okay. So they've written ibuprofen, indomethacin, PCM. Okay. And what about the dose? What is the dose of paracetamol? What is the frequency? Dr. Sumit, frequency, 6 hourly. And how many days? Okay, Dr. Yusuf, you can tell the answer.
Yes, yes, okay. So we'll see. So basically, paracetamol will be giving. So let's just move to the next slide only. So we have most of these. So paracetamol, it is given as 15 mg per kg per dose every 6 hourly for a total duration of 3 days. Ibuprofen, basically there is a high dose ibuprofen as well as a low dose. But as per the Cochrane recent evidences, the most efficacious of them is basically the high dose ibuprofen, which is basically 20 mg per kg loading followed by 10 mg per kg we give for 2 days, 24 hours apart. And indomethacin, it was used in the prior times. However, it is not used in this condition. So it was used at a dose of 0.2 mg per kg for a total of 3 doses, 12 to 24 hours apart. So could you tell me some specific benefit of using indomethacin, which it was used in the prior times? However, its use has gone outside the practice of neonatology these days.
Yes. IBH prophylaxis, someone has written.
Yes, yes. So this was used for preventing IVH. So what is the recent meta-analysis? So basically, treating a PDA is actually a clinical conundrum. We don't know if we are treating whereas is this duct actually leading to some complications and whether it will have any long-term outcome or not. So a recent meta-analysis of approximately 10 randomized control trial showed that the expected management, that is, you just leave the PD as it is and don't actively manage. It may actually be associated with better outcomes than actively managing this PDA.
So can
Okay.
anybody tell what is the mode of action of paracetamol in PD? Mechanism of action of paracetamol in PDA closure? No. Peroxidase inhibition. Okay, Dr. Subarna, she is correct. So it's a peroxidase inhibitor, PDA, and ibuprofen, indomethacin are cyclooxygenase inhibitor. POX pathway, correct.
Okay, so this is the basically the echo. What do we actually assess in the echocardiography when we are assessing the hemodynamic significance of a PTA? So the ones which are highlighted are actually of clinical use and actually help in deciding the severity of PTA. So one, we measure the diameter, then whether we see whether what is the flow type, what is the flow pattern of the PTA. I will be discussing each of them and their images in the next slide. The third is basically the velocity of the PTA in both systole and diastole. And then for a marker of pulmonary overcirculation, the most commonly used marker is basically the left atria to aortic ratio. Then to assess the the left-sided pressure being overloaded, we have the mitral E is to A ratio, that is early diastole to the active atrial filling, and the isovolumetric relaxation time, the IVRT. And then to assess for the ductal steel, we assess the flow direction in any of the following vessels, the aorta descendant, the celiac trunk, and the middle cerebral artery. So just so this is a table. So I just first go to the images that will be much more clearer. So as you can see, this is a typical ductal view with three-legged stool. So this is the PDA. We'll be measuring the diameter of PDA at the pulmonary end. Then when we apply a color wave, a continuous wave Doppler on this PDA, we can have these following four flow waveforms. So what are these flow waveforms and which waveforms? Okay, so can you, amongst option number C, D, E, and F, can you tell which of the waveforms we have to actively treat and which waveforms which can we can actually let go, and waveforms which should we should never treat? Yes, so most of you are saying it correctly. So this is basically the continuous waveform. That is the C waveform is what we should actively see. So this is basically a non-restrictive left to right flow. So what is there? Basically, the difference between the systolic and diastolic velocity should be less than 30%. However, if it is more than 30%, it basically that waveform we should not treat. So this is basically a restrictive flow. So we have to treat a non-restrictive PDA and not a restrictive PDA. And the other two are the common waveforms which we see when we are dealing with a baby with PPHN. So a bidirectional flow, where the flow waveform uh, as well as a right to left, complete right to left flow. So these two waveforms we shouldn't be treating. Then this image, what is this image showing? So this is basically the parasternal long axis view. So here there is an M mode cursor which is on, and then this is the M mode cursor profile. So we have basically the iota, sorry, this is the LA and this is the iota. So we will be measuring the LA to iota ratio, which will be, if it is more than 1.5, in this case it was 2. So this is actually a marker of pulmonary overcirculation, and it indirectly signifies that this PD is probably hemodynamically significant and probably worth treating. Then the other thing in this image is basically what you can see are we are attempting to measure the systemic ductal steel. So how do we see for that? So we look at the flow waveforms, the diastolic flow, whether it is preserved, absent, or reversed in the following vessels, that is SMA or the celiac trunk, or we can also do it in the middle cerebral artery.
So can anybody tell what are these three flow waveforms of SMA? So extreme left, the middle, and right one. You can write in the chat box. SMA flows. What is the left one? Okay. Okay, fine. So it's a forward flow, then AEDF, and this is REDF. Okay, perfect.
Correct. Okay. Then this is basically the E is to A ratio and the IVRT. So where do we measure E is to A? So
Mm.
how do we measure actually? Can anybody tell?
EA ratio. Please, anyone can write in the chat box.
Yes,
Mitral valve.
yes. And what Doppler will be applied? Will be apply a pulse wave Doppler or a continuous wave Doppler? Yes. So we will be applying the pulse wave Doppler. So what is this actually? So as you all know that there will be a increased blood flow to the left side of the heart. So what is E and what is A wave?
What does E and A denote?
Yes, very good. So basically, E wave is basically the passive diastolic filling. So whatever the blood was there in the left atrium, it actually comes directly into the left ventricle passively. Whereas, and this is in the initial part of the diastole. In the latter part of the diastole, what will happen is that there will be active atrial contraction. So in a normal preterm neonate, the E wave it is because of the immaturity. Basically, the E is to A ratio is usually less than 1. However, when there is increased blood flow to the left side of the heart, what happens is there is earlier diastolic filling as well as increased diastolic filling. So E wave, the contribution of E wave will increase. So the E is to A ratio will become more than 1. This is also known as pseudo-normalization of E is to A because E-A ratio is more than 1 in usually older infants. And here a preterm baby is having a waveform which is similar to what is perceived to be normal in older babies. So this is also known as pseudo-normalization of E-A ratio. And what is the next image showing? It is basically IVRT. What is
What is
IVRT?
IVRT? Expand, na? Expand. What is IVRT? Isovolumetric relaxation time. Yes. What is it? What is it? So this is basically the time, basically a time from the uh, aortic valve closer to mitral valve opening.
Yes. So as we have already discussed, since there is increased blood flow in the left atrium, so mitral valve, because of the sheer overload of the left atrium, the mitral valve will open earlier. So the isovolumetric relaxation time will actually decrease. So it is usually less than 45. Okay. So these are the basic images. So this is how you actually classify a duct. First, on the basis of morphology, what is the size of duct? That is less than 1.5, 1.5 to 2, and more than 2. That is small, mid, moderate, and large duct. Then we see for the important, that is LAO ratio, if it is less than 1.5, 1.5 to 2, or more than 2. Then other important thing is basically the IVRT, as we mentioned, that if it is more than 40 is for a small, between 30 to 40, and less than 30 will be for a large duct. Apart from that, the forward flow is suggestive of a small shunt, whereas absent or reverse flow will show that there is increased severity of the hemodynamic significance of that PDA. And then, okay, so let's next we go to the next slide.
Okay, so this is a 21-day old neonate presented with bluish discoloration of lips on crying. Since past 2 weeks, there is no history of suck cycle, sweating or cough or breathlessness. And on clinical examination, uh, reveals a heart rate of 110. Baby is having tachypnea, respiratory of 64 per minute. There is central cyanosis that is worsened on crying. So these are some of the questions. So define cyanosis and what are its determinant? What are the different types of cyanosis? What could be the causes? How do you approach in history and examination? What is hyperoxia test?
डॉक्टर
What's the
तपस
gold standard test?
तपस ये ना किसी ने एनोटेशन हो गया है बीच में ना ये रेड रेड दिख रहा है कुछ आ रहा है कैन यू जस्ट रिमूव दिस रेड लाइंस व्हाट इज दिस
Mm, how to remove this?
It's done, I think. I think now it's must be done. So,
Uh-huh. It's done.
mm,
So, how do you define cyanosis? Okay, so deoxygenated blood of more than 4%. So precisely it is more than 3 gram per deciliter in arterial blood or more than 5 gram per deciliter in capillary blood. So what are its determinant? What are the factor which determines cyanosis? Okay, so it's determined by the hemoglobin concentration. Like in babies with polycythemia, like if the hemoglobin concentration is high. Okay, so like if suppose a baby is having polycythemia with a hemoglobin of say 23 and say the saturation is 85%. So what will be the percentage of deoxygenated hemoglobin? So 15% of 24 will be how much? 15% 24 will be how much? 3.6. Okay, and but suppose there's one baby having a hemoglobin of say saturation of 85 and hemoglobin of 10. So what will the percentage of deoxygenated hemoglobin? So that will be 1.5, right? So the same babies, so with the same saturation, a baby having polycythemia with a hematocrit of hemoglobin of 24 will show cyanosis because the reduced hemoglobin value will be more than 3, so 3.6. Whereas the same baby, if is anemic with hemoglobin of 10, so baby will not show cyanosis even with a saturation of 85% because the deoxygenated hemoglobin concentration is only 1.5 gram per deciliter. So hemoglobin, the concentration hemoglobin determines the cyanosis. Other factors are like acidosis, hemoglobin F concentration, and the skin color of the baby, which determines the cyanosis. So what are the different types of cyanosis? What are the different types of cyanosis, you know? Central, acrocyanosis, differential cyanosis, and reverse differential. What is acrocyanosis? What do you understand by acrocyanosis? Okay, so in acrocyanosis, the cyanosis is actually limited to the extremities and the lips. Extremities and the lips. The baby will have a normal saturation and a normal PaO2. Whereas in case of central cyanosis, the cyanosis will be more evident in the limbs and the mucous membrane, like in the tongue, in the cheeks. You can find cyanosis, and the babies usually will have a lower SpO2 and the PO2. The cause of acrocyanosis is due to local vasoconstriction and sluggish circulation, like in babies with hypothermia and polycythemia, as I've said. Whereas central cyanosis can occur because of respiratory or the cardiac condition and because of shunts. And what about differential cyanosis? What do you understand by differential cyanosis? Someone has written differential cyanosis. What is differential cyanosis? Okay, so if the cyanosis is more in the lower limb as compared to upper limb, it is known as differential cyanosis. So where do you find a lower limb to be more pink as compared to upper limb? Sorry, lower limb to be more cyanosed as compared to upper limb? Yes, lower limb cyanosis. So what is the condition in which you found the lower limb to be more cyanosed as compared to upper limb? No. Yes, coarctation is correct. So any condition that will lead, which has got a very higher pulmonary resistance, which will prevent the blood to flow to pulmonary circulation and will shunt the blood from the RV to the descending aorta via PDA, will have a differential cyanosis. Okay, like in babies with PPHN, where the pulmonary blood flow is less, and pulmonary blood flow is less, or in babies with severe coarctation of aorta, where the circulation to the descending limb is maintained by the PDA. So in those cases, you can find a differential cyanosis. So coarctation of aorta, interrupted aortic arch, or severe PPHN, you can find the lower limb to be more cyanosed as compared to the upper limb because of shunting of the deoxygenated blood across the PDA to the descending aorta. And what about reverse differential cyanosis? What about so please, all the participants, please mute yourself. So what about reverse differential cyanosis? Where do you get a reverse differential cyanosis? Yes, correct. So it is seen in babies with TGA. So what are the causes of cyanosis? So Dr. Yusuf, you can go to the next slide. Yes, I think it's very the font is very slow. So the causes could be start well from the airway. So they could cause like in babies with corneal atresia. So what is the characteristics cyanosis you can see in babies with corneal atresia? So normally it is evident in babies with bilateral corneal atresia. In lateral corneal atresia, babies remains asymptomatic. However, in babies with bilateral corneal atresia, what is the classical clinical manifestation? Yes. So whenever the baby is like not crying, the baby will look cyanosed. When the baby starts crying, the cyanosis will go off. Correct. So you can also be seen in babies with Pierre-Robin sequence, micrognathia, laryngomalacia, etc. You can see from your book. Then it can be because of lung conditions like parenchymal lung disease or non-parenchymal lung disease. So, like in case of preterm, the cause could be like HMD, it could be TTN, and in term babies, it can be TTN, meconium, pneumonia, etc. So, next is the cardiovascular causes because of PPHN or because of congenital cyanotic heart disease or pulmonary AV fistula. Sometimes it can also occur because of defective hemoglobin, like presence of excessive amount of methemoglobin or sulfhemoglobin, and some of the miscellaneous causes like sepsis, hypo. You can read it from any textbook of neonatology or pediatrics. This etiology you can find. So next question is, what is the like history and examination? What important thing you will ask in the history for upper airway malformation? For upper airway malformation, what history you can find? Okay, history of polyhydramnios. So polyhydramnios can be there, which indicates airway anomalies, or it can be because of like TEF. You can have polyhydramnios. Then it also see for the presence of diabetes in the mother, because diabetes increases the risk of developing cyanotic heart disease like DTGA. It also increases risk of pulmonary conditions like HMD, hypoglycemia, etc. Then you can ask about the history of fever, PPROM to rule out sepsis, etc. And then you have to ask regarding the day of onset and day of onset, the severity of cyanosis, whether the baby is having more of cyanosis than respiratory difficulty. Like that, you can ask the examination in the history. In the examination, you have to evaluate for the airway, breathing, and circulation. For the presence of RD, never ever forget to look for the dysmorphism, because you can find some subtle dysmorphism in babies with periorubin sequence, and then if you find there's upper airway obstruction, you can easily make a diagnosis of periorubin sequence. And evidence of CHF, hepatomegaly, liver-sidedness like heterotaxis syndromes, all those you should see. Then you should take a thorough vitals of the babies, and you should auscultate for the rhythm. Then you should check for the S2. The second heart sound is typically single in babies with cyanotic heart disease, and you should also see for the apex beat where it is like on which side, and you should also auscultate for the murmur. Now coming to the most important test, that is hyperoxia test, which is not being done nowadays. So can anybody tell what is hyperoxia test and how it is being done? 100% oxygen for 10 minutes, okay, and you should see for the PO2 in the right radial artery. So if it is more than 250, the PO2 is more than 250, it is past hyperoxia test and it excludes critical congenital heart disease. However, if the PO2 is less than 100, or if the rise in PO2 after providing this 100% oxygen for 10 minutes is less than 30, and the chest X-ray is not showing any lung pathology, then it is known as failed hyperoxia test. So these babies should be started on PG1 infusion. However, remember that sometimes you can find false past hyperoxia test in babies with complete intracardiac mixing lesions, like in babies with truncus arteriosus or hypoplasia with complete mixing, or in babies with TAPVC. Or sometimes you can have a falsely fail hyperoxia test, like in babies with severe PPHN, in which the oxygen providing 100% oxygen even will not increase the PO2 to sufficient value to rule out like CCST. So these are like caveats of hyperoxia test. Nowadays, with the availability of echocardiography, these tests are easily not being done, because for preterm unit, it can increase the risk of ROP also. And eventually, even if you make a diagnosis, these babies should be confirmed. The diagnosis should be confirmed by echocardiography. So what is the gold standard test to detect hypoxia? ABG, correct. So any role of chest X-ray in babies with cyanotic heart disease? So what all you want to see in chest X-ray? So in chest X-ray, what all you want to see? Okay. So Yusuf, next slide. Yes. So this is a approach chest X-ray approach to baby with a cyanotic unit. So you have to see for the position of the heart, abdominal situs, presence or absence of cardiomegaly, pulmonary blood flow, and the lung parenchyma. These five things you have to see: the heart position, heart size, pulmonary blood flow, and the lung parenchyma. So if you have a cardiomegaly with increased pulmonary blood flow, the possibilities in the first week of life would be TGA or admixture physiology with no pulmonary stenosis. However, if the baby is having a huge cardiomegaly with a reduced pulmonary blood flow, the diagnosis would be Epstein's anomaly. So in Epstein's anomaly, we find a huge cardiomegaly with a black lung, the reduced pulmonary blood flow. If there is no cardiomegaly with a normal pulmonary blood flow, it can be because of single atrium physiology or because of anomalous systemic venous drainage. If there is no cardiomegaly and the blood flow is reduced, like if we find a like black lung, it is because of TOF physiology or pulmonary stenosis with intact ventricular septum, or if there is no cardiomegaly and there is a pulmonary venous hypertension, so it can be because of obstructive TAPVC. So you can see some of the X-rays in the next slide. Next slide, please. So what is this X-ray? The first one. What is this X-ray A? So what you can see in this X-ray is there is a cardiomegaly. Is there a cardiomegaly? No, there is no cardiomegaly, but you can see there is a pulmonary plethora. Can you see this? So you can see the pulmonary vessels are too much there. You can trace out till the end of the lung fields also. So, so based upon that algorithm, there is no cardiomegaly, but there is a pulmonary plethora. So because this is because of pulmonary venous hypertension. So what could be the reason? Yes, obstructed TAPVC. What is the next X-ray? So what you can see a cardiomegaly. Okay, there is a wide pedicle. Yes. So this is agon side appearance. Okay, so it's cardiomegaly with narrow pedicle, and there's a plethora also. You can see the plethora on the X-ray B. You can see there's a plethoric lung fields. There's a cardiomegaly with a narrow pedicle. Classical agon side appearance because of TGA. What is the third X-ray? What you can see third X-ray? Supracardiac TAPVC. Correct. So what you can see in this X-ray? You can see the cardiomegaly, and you can see the figure of 8 appearance classically seen in babies with supracardiac TAPVC. What is the last X-ray? TOF. Correct. So there's a boot shaped third, and you can see the lung field. You can compare the lung fields on the X-ray A and the X-ray D. See the lung fields. These are very dark lung fields as compared to X-ray A, in which the lung fields are more hazy. Also in the also in the X-ray B, the lung fields also hazy. But in D, you can see the lung fields are like too much dark. Okay, so there's a decreased pulmonary blood flow with a boot shaped heart, and there's no cardiomegaly. There's oligemia, so it indicates TOF. Correct.
We go to the next question. So this is a term baby who was born through meconium stained amniotic fluid. The baby had respiratory distress after birth. So we put the baby was initially put on CPAP support, but in view of worsening distress and increasing FiO2 requirement, baby was intubated and was started on mechanical ventilation. So baby is presently on assist control mode of ventilation with the following settings of PIP of 25, FiO2 requirement of almost 100%, TI of zero point 0.4, and the baby has a saturation which is hovering between 88 to 92%. The pulses are well felt. The CRT is less than 3 seconds, and the BP for us is basically 58 with a diastolic of 32 and a mean of 42. The blood gas analysis revealed a pH of 7.3 with a PO2 of 50, PCO2 of 32, and a bicarb of 17. So, what are the important differential diagnoses that you would take in this case? Okay, so mass PPHN. Okay,
Else, what else? Mass PPHN and
very good. Air leak.
air leak.
Yes, yes. CHD. Okay. So, how would you plan the investigation in this baby? Yes, so basically chest X-ray and echo will be usually giving us a fair deal of idea what is the condition which we are actually dealing with. So we have the following, you have all the following parameters. You have the blood gas parameters, you have the saturations, then so can you calculate, and then you have the ventilatory settings. So can you calculate the OI and as well as what is, okay, first tell what is OI, then what is OSI, and is there a relationship between the two of them? And then how do we calculate in this case?
Calculate the OI. All of you calculate the OI. To calculate the OI, you have to calculate the map first. So what would the map? Map, what is the formula of map? So map will be 6 plus PIP minus PWP, that will be 19, into TI, that is zero point 0.4, by total time. Total time will be 1.5.
Yes, so most of you are correct. So the important differential diagnosis which we will be dealing with this case are MAS, then PPHN. Obviously, we should not forget pneumothorax, and definitely a cyanotic congenital heart disease will always be on the cards. So three important investigation which we can do in this baby urgently, because since sometimes X-ray may not be urgent, so we can do a transillumination test to rule out the air leak, and then do a point of care echo
Mhm.
to see if the structures are normal and if the baby is having features of PPHN, and finally an X-ray. So OI is calculated as MAP into FiO2 divided by the arterial oxygen, that is PaO2, partial pressure of oxygen, which is calculated in the VBG. And OSI, since you cannot always be doing invasively ABGs for all babies, so this is a surrogate markers. We use OSI, where we instead of PaO2, we will be using the SpO2. And what is the relationship between OI and OSI? So it is almost 2. So OI is approximately 2 times the OSI. So
Map, I
now,
think in this case will be 12. So
well,
24, right? Map will
yes,
be
sir, yes,
12,
sir,
so
yes, sir,
OI will be 24.
yes, sir.
Yeah.
Okay, so now we went ahead and did an echo as we were discussing previous also. And these are basically the three images, the four images which are being shown. So can anybody please, can all of you tell what are these five images actually signifying? Sorry.
Hmm. Please write your response. First, second, third, fourth, and fifth image. Okay, first is TRZ, second is eccentricity index, third is TAPSE. What about fourth? This fourth image was discussed previously also.
Previously also, yes.
Okay, I think they have written correct.
So let's just go. So the first image is basically the TRZ. The second is basically the eccentricity index. So eccentricity index. Okay, so how do we calculate? What is the formula on which the TRZ? What is the TRZ indirectly calculating, and how it does it calculate? What is the formula or what is the equation it uses? Yes,
4V square plus 5.
yes. Okay. So it indirectly estimates the right atrial pressures. Okay, pulmonary arterial pressure. Sorry. What is the eccentricity index? So basically, eccentricity index is nothing but normally as the severity of PPHN increases, initially there will be septal flattening, the IVS, the intraventricular septum will flatten out. However, with further increase in the RV afterload, the RV will start to the pressure in the RV will build up to such an extent that the intraventricular septum will start bulging towards the left ventricle. So what we are here measuring is basically in the eccentricity index. This is the interventricular septum. So which we are measuring basically what is the dimension of in the systolic phase. It is basically systolic eccentricity index. So at the end systole, we'll be measuring this diameter between the two muscles, and then we will be measuring from the free wall of the left ventricle and the intraventricular septum. If it is more than one, that means there is increased pressure load of the right ventricle, which is causing the septum to bulge towards the left side. So this is a indirectly marker of greater degrees of raised pulmonary PPHN, increased
So
severity of PPHN.
basically, it basically quantifies the distortion of the LV chamber because of increase in the RV pressure.
Okay. What is this? What is first? Can you tell what is the mode? Which mode of echo which are we using in this condition? And what is this actually?
What? Let's see.
Yes. So can you what is the full form of TAPSE? Yes. So how
Mm.
do we define what is the value of TAPSE which signifies severe PPHN? Yes. So it is less than 4. If your TAPSE is less than 4, it is significant of severe degree of PPHN. Okay. So what is figure 4? So figure 4 we discussed even in the slide where we were talking about the PDA, the flow patterns of PDA. So there the flow basically during diastole also there is a more than 30% of the flow is during that phase. So this is a bidirectional flow at the level of PFO. Okay. And then what is this? Figure 5. So almost the same thing. Okay. So let's just first go to the next slide and see for the answers. Yes. So first figure was TRZ. It is used to estimate the degree estimation of the pulmonary pressures. Second, as we all discussed, it is the eccentricity index, which is measured in N systole. It is the distortion of the LV cavity. The figure 3 was determining the tricuspid annular plane systolic excursion. A value of less than 4 is indicative of severe degree of PPHN. And figure 4 and figure 5 were basically bidirectional shunt. One shunt was measured at the level of the PDA, and the second was measured at the level of the patent foramen ovale. Okay, so what are the important points in the pathophysiology would you keep in mind while you are managing this baby? Important things, whether you're ventilating, whether you're managing the hemodynamics, what are the important points in the pathophysiology of the disease?
Adequate recruitment.
Yes,
So adequate recruitment in this case using what methods? You have seen the settings and the blood gas already.
yes, yes.
Okay, so surfactant, high frequency oscillation. Okay.
Okay, okay, okay. So, okay, let's just first go to the slide and just see. So basically, as you all know, actually there are four types of mutation, three types: maldevelopment, maladaptation, and underdevelopment. Okay, so irrespective of what is the underlying pathophysiology, whether it is most commonly what is the type of PPHN we are dealing with, mostly it is secondary type of PPHN, where in most of the cases we will be having an underlying parenchymal lung disease, whether it is due to MAS or due to pneumonia. Okay, then second important pathophysiology, which we see very less likely, is basically an idiopathic or a black lung PPHN or a primary PPHN, where it was primarily the vascular remodeling that has contributed to the elevated pulmonary pressures, and the parenchyma is not afflicted in this case. And the third condition is basically there is underdevelopment, that is in cases of CDH, where there is pulmonary hypoplasia. So apart from the parenchymal hypoplasia also, there is vascular hypoplasia. So basic things in the PPHN management that we have to do is basic, mainly four. One is supportive management. Second important thing is that we have to do adequate lung recruitment. Third thing, we have to maintain the systemic blood pressures. And the fourth thing which we have to do is basically decrease the pulmonary pressures. So these are basically the four-pronged strategy when we are managing any babies with PPHN. So one is strategy is lung recruitment. So how would you recruit the lung? Providing adequate ventilation, early surfactant therapy. How can we provide? By providing adequate ventilatory support. If the baby is failing conventional ventilation, then we shift these babies proactively to rescue HFOB. And uh, sometimes we will be we might need surfactant. So what is the indication of giving surfactant as per the NNF guidelines in
What is
babies
it?
with
What is the criteria? When do you give surfactant babies with PPHN due to meconium aspiration syndrome? OI of more than 15, correct.
Yes. Okay. So at OI of more than 15, we will consider giving surfactant in these babies. And the third, obviously, if these babies, if there is a setting of underlying sepsis, we will provide these babies with appropriate antibiotics. Then second important thing is after having adequate lung recruitment is basically lung protective strategy. That is also important. So what is the important thing in lung protection that you like to be very sure of when you are ventilating these babies? What is open lung recruitment? Open lung strategy, sorry.
Open, keep it open.
Yes. So you open the lung and you keep it open. Okay. So you provide adequate pressures and to open to recruit the lung, and then you provide adequate weave or map to keep these recruited alveoli open. So this was the first aspect of PPHN management. That is, you are providing adequate lung recruitment. Second important thing is basically providing supportive care. So what are important components of supportive care that you should be very careful when you are managing these babies?
Okay.
Yes. Yes. So very good. Minimal handling, providing adequate sedation, avoiding noise,
Hmm.
light, then maintaining euglycemia, maintaining normal sugars, maintaining normal hemoglobin, ruling out polycythemia. So these are some of the maintaining normocalcemia. So these are some of the important supportive strategies that you would look in this case. So the third and the fourth component are basically maintenance of the systemic blood pressures and then and selective pulmonary vasodilatation. So as you all know, this it is a fine balance. That is, the pulmonary pressures are high, and at the same time, since there is septal bowing, which we have seen in cases of towards the left side, there will be there will be systemic hypotension also. So you have to strategize your hemodynamic management such that we are improving the mean arterial pressure as well as providing selective pulmonary vasodilations. So what is the drug of choice or important selective pulmonary vasodilator that you used in this condition?
What else? I know sildenafil.
Okay. Yes, very good. Are
Yes.
there any inhaled agents also?
Iloprost.
Yes. Okay. So
Okay.
we'll be discussing them subsequently further. Okay.
I think go to next
Yes.
question.
Yes, sir.
So this
What
is
is this?
question fifth. So what is the indication? So you see this device on right hand side, the image of the device right hand side. So what is the indication of using this device? What is the mechanism of action? What are the prerequisite prior to starting the therapy? What are the contraindication? What are the initiating dose and how do you say baby has responded to it? And what are the side effects? First, indication of use. Okay, OI of more than 2025. What is the gestation above which it is recommended? Okay, more than 35 weeks. Okay, more than 34 weeks. Okay, and how does it act? What is the mechanism of action? Okay, increase in the CGMP level. Okay, so what are the prerequisite prior to starting the treatment? What are the prerequisite? What are the criteria to start INO treatment in babies with PPHN? 20-20-20 rule. Good. And what is the tapering rule called? 60-60-60 rule. What are the contraindications of using INO? Okay. Okay. What is the dose to initiate INO and how do you say the baby has responded? You already discovered 20-20-20 rule. What are the side effects? So let's go to the answers.
Yes, sir.
So it is indicated in babies more than or equals to 34 weeks having with hypoxemic respiratory failure defined as an oxygenation of index of more than 20 or some centers say it is more than 25. But majority center it is saying like more than 20. So basically this inhaled nitric oxide it diffuses inside the cell and then it activates the soluble guanyl cyclase So what is the role of this soluble guanine cyclase? So basically it is responsible for conversion of GTP to cGMP. So by activating this soluble guanine cyclase, it increases the level of cGMP, and then this cGMP actually decreases the level of intracellular calcium, causing the relaxation of the pulmonary vessels musculature. So, as already being discussed, adequate lung recruitment, absence of LV dysfunction, and absence of ductal dependent systemic circulation, particularly infracardiac TPPC, should be ruled out. And if you use this drug in babies with LV dysfunction, that can actually deteriorate the pulmonary venous hypertension and the pulmonary edema, and can further lead to pulmonary hypoxemia. So these three things are very important. So as I've said, so ductal dependent systemic, the contraindications are ductal dependent systemic circulations, severe IVH, LV dysfunction, and methemoglobinemia. So response is, so we start with 20-20-20 rule. So you give it 20 ppm. So the response is defined as a increase in the PF ratio. So we calculate the PaO2 by FiO2 ratio. So if this PaO2 by FiO2 ratio increases by more than 20 millimeter of mercury after 20 minutes of starting INO, that is known as a complete response. And the side effects of this treatment are like platelet dysfunction, methemoglobinemia, and production of toxic byproducts such as nitrates, which are usually monitored while you are giving this treatment to babies with PPHN. So here you can see on left hand side initiation 20-20-20 rules. So start at a OI of 20 or more. The dose is 20 ppm and response is defined as a PF ratio increased by more than 20 millimeter of mercury. So after you start it and the baby is showing a response, so response usually is demonstrated by 60 minutes of starting the treatment, and response is defined as the oxygen requirement of FiO2 below 60% with an increase in the PO2 of more than 60 millimeter of mercury. So whenever you get a response, so you start weaning off the, so initially when you get a response, you start weaning off the FiO2. Try to bring the FiO2 to less than 60%. Simultaneously do a blood gas. You see the PO2 more than 60. So you start weaning off the INO by 5 ppm every 4 hourly until you reach a dose of 5 ppm. So like we started with 20, so reduce it to 15 after 4 hours. If the baby is like maintaining the response, you again reduce it to 10 after 4 hours. If the baby is maintaining the response, then you reduce it to 5. So after reducing to 5, you decrease by 1 ppm every 4 hours till discontinuation. So successful winning is defined as if the baby is maintaining a stable SpO2 and PO2 of more than 60, and FiO2 does not increase or increases by less than 15% during the course of tapering of the INO. And winning failure is defined when the SpO2 drops by more than 5% and FiO2 increase is required more than 50%, 15% to maintain the target SpO2 or a PO2 of more than 60 millimeter of mercury. So sometimes you may not find a response in some of the neonates, particularly in babies with CDH or in babies with LV dysfunction, or when your recruitment strategies are not good or the baby is in shock. So in those cases, you should try to optimize your oxygenation by lung recruitment, appropriate ventilation. You should like be considering fluid boluses and inotrop, particularly the baby is in shock or there is a RV or LV dysfunction. If there is still there is no improvement in PO2 SpO2, you have to discontinue the INO treatment. So you can consider ECMO or transfer to a center providing ECMO, particularly if the baby is not responding to INO and there is a severe hypoxemic respiratory failure, and also if there is a severe hemodynamic instability that is not being managed by this treatment. And with a OI of like more than 40 OI, you transfer to a ECMO center and initiate the ECMO treatment.
Okay. So further discussing the PPHN. So these are basically two drugs. So discuss the mechanism of action, the dose, the mode of excretion, and the side effect. So first drug is basically palmosil or sildenafil. Could you please discuss what is the mechanism of action? What is the dose that you give it?
Phosphodiesterase 5. What is the dose of sildenafil? Dose. Do you need to give a loading dose also? Okay. What is the loading dose?
Okay.
Okay. Mode of excretion, liver. And side effects? No, it is not renal, it is liver. Okay. Most important side effect. Hypertension. Okay. Okay,
So
Yusuf, you can.
yes, sir.
And what about the
And
second
then
drug?
second drug.
Second drug. Yes. Mechanism of action of milrinone, phosphodiesterase 3 inhibitor. Okay. Indication of use in PPHN. Okay. Dose, side effect, contraindications. Do you need to give a
Um,
load in this case? Do you give a milrinone loading also? Okay, someone is writing yes. Okay, Yusuf, you can go
yes,
to.
sir. Yes, sir. So sildenafil, as you all correctly said, that is basically phosphodiesterase 5 inhibitor. So we give a loading dose of 0.4 mg. Sometimes we can avoid because of the risk of hypertension when it is given as a continuous IV infusion at a dose of 1.6 mg per kg per day. The mode of excretion is hepatocellular and the important side effects are hypotension, and then it can also cause platelet aggregation abnormalities.
So how does
Coming on,
phosphodiesterase 5 inhibitor is where does it is acting phosphodiesterase 5? So for I know I told that from GTP it is converted to GMP by soluble guanyl cyclase. No, no, no. So basically, it prevents the breakdown of GMP. Uh, uh, Breakdown of GMP. Yes. So by that it maintains the level of GMP and causes vasodilatation. What about
so
milrinone?
it actually acts as an additive response. It can act as an additive response to your INO also. When
Yes.
INO is increasing your cyclic GMP, but sildenafil is actually inhibiting its
Breakdown.
destruction breakdown.
Yes. Okay. Milrinone.
Milrinone. So what is milrinone? Is basically phosphodiesterase 3 inhibitor. So milrinone is basically an inotrope as well as a lusiotrope. So what is a lusiotrope? Inotrope you all must be knowing. What is a lusiotrope?
Hmm. Relaxation. Okay.
Yes, so it basically increases the rate of diastolic relaxation, which will help in basically promote increasing the preload as well as allowing the coronaries to be perfused. So it is where milrinone is used. So how does milrinone act? Is basically by acting as phosphodiesterase 3 inhibitor. So it increases the level of cyclic AMP. It acts on the cardiac myocytes as well as on the vascular smooth muscle cells. So in the vascular smooth muscle cells, it causes vasorelaxation. So it actually acts as a vasodilator. It acts as a vasodilator specifically across the pulmonary vascular bed. So helps in basically babies with PPHN, and by increasing the contractility and the lusotropic, inotropic as well as the lusotropic effect, it will help in cases of LV dysfunction also. So what is the important side effect which we are very worried when we are starting any babies on milrinone?
Hypertension.
Yes, so it is hypotension. And how it is excreted?
There's a figure on right hand side. Renal
Renal.
excretion.
Yes.
So
So
this
it
is
is
very
excreted.
important because in babies with asphyxia, you can have a renal injury because kidneys are most commonly affected organ in asphyxia. So that can actually inhibit the excretion of milrinone from systemic circulation, and then it can build up the levels in the blood and can cause the side effect of hypotension and a prolonged hypotension also. So because of hypotension, generally the loading dose of milrinone are not provided. You generally start with a maintenance dose of milrinone while managing babies with PPHN.
So this is just the same thing which we have discussed already. So let's just now go on to the next slide. So this is
Okay.
another agent.
Mm.
Yes. So
So what
same
is the
question.
yes? What is the mechanism of action of this drug? What are the indication of its use? So this is alprostadil, alpostin. It comes in name of brand of alpostin. This is PGE1. What is the mechanism of action? What are the indication of use? What is the dose? What is the side effects? Which condition can show worsening by its use? Mechanism of action. Okay, so it maintains the okay PGE1 pediatric indication for use in babies. What are the indication of its use? Any use in babies with PPHN? When do you use this drug in babies with PPHN? Okay, RV dysfunction. What are the side effects of this drug? Side effect.
Yeah.
Okay. Okay.
Mm.
Okay. And which condition, if you use this drug, can actually show worsening? Or in which condition you will avoid using this drug? Okay. Tab VC. Any other condition?
Yes. HLHS.
Okay. Perfect. So let's go
Yes.
to. So this is IV PG1 infusion. So it basically maintains the patency of the arterial duct, resulting in duct dependent in babies with duct dependent systemic and pulmonary circulation. Also, it is used in babies with severe PPHN when like there is a RB dysfunction and RB dysfunction which is not being responding to the milrinone and inotropes. So you try to open the ductus arteriosus so that the RV pressure actually get decompressed into the systemic circulation. So this is one of the use of PG1 in babies with PPHN also. The dose, the typical dose is like 0.05 microgram per kg per minute, and then you hike it by 0.01 whenever you are using babies with CCHD. So you start with 0.05 mics per kg per minute, and you hike it by 0.01 mics per kg per minute every 15-20 minutes depending upon the response. The maximum dose is like zero point 0.1 mics per kg per minute, and you can go up to zero point 0.2 mics per kg per minute also. Remember that the dose of PG1 is higher in babies whenever using in babies with ductal dependent systemic circulation, okay, as compared to babies with ductal dependent pulmonary circulation, because it has got a very high first pass metabolism in the lungs. So that's what so because of that, whenever you're using in babies with systemic circulation, you might require a higher dose. So the typical side effects are like flushing, fever, apnea can is the most dreaded side effect of using PG1. It's a dose dependent effect of PG1, and a prolonged infusion can actually lead to gastric outlet obstruction and can also lead to hypertrophic cortical hyperostosis, that is known as Barrett syndrome also. So these are all dose dependent effects. So whenever you get a response, you try to reduce the dose of the drug by 0.01 mics per kg per minute to a minimum dose of 0.01 mics per kg per minute. So whenever you bring down the dose to minimum dose, the chances of developing the side effect, particularly apnea, gets minimized. So what are the contraindications or the condition in which it can show worsening? So it can worsen in babies with obstructive TAPVC because of increase in the pulmonary venous hypertension, and like in babies with HLHS with obstructive AST, or mitral atresia with obstructive AST. So basically in all of these conditions, there will be increase in the pulmonary venous hypertension and pulmonary edema if you use PG1 in this case, in these cases. So these are the three contraindications of using alprostadil infusion in babies with CCHD.
The next question is
Yes.
basically a 39-weeker male neonate, 3.97 kg, born by LSCS to a mother who had poorly controlled gestational diabetes mellitus. The baby had smooth perinatal transition. However, on during your rounds, you notice that at 24 hours of life, this baby is having poor feeding and there is tachypnea. So you did a sepsis screen, you ruled out sepsis, you did polycythemia, you ruled out polycythemia. There was no hypocalcemia. So then we went ahead, since the baby was having tachypnea and poor feeding, we went ahead
Mm.
and did a chest X-ray and echo in this baby. So let's see what this chest X-ray and echo show. So can anybody tell what is this condition that we are dealing with?
We already discussed this. This is cardiomegaly with increased pulmonary blood flow. Okay, we haven't discussed this. Okay, okay. No. Yes.
Is it TGA? No.
Is this TGA? See the echo picture.
See this. What is this?
Mm.
Yes. Okay. So this is basically a case of asymmetrical septal hypertrophy. Okay.
Mm.
So this is basically asymmetric septal hypertrophy. So how does it, what is the pathophysiology of this? Single word, if I have to ask, what is the important words that we should know of? Yes. So basically, better would be to say a dynamic LVOT obstruction. Okay. And then what additional thing would be contributing to this LV obstruction? Since the ventricle is very much thickened, there will be additionally which valve will actually cause further worsening of the obstruction. So there will be, apart from a dynamic, so LVOT obstruction, there will be the anterior movement, the systolic anterior movement of the mitral leaflet, which will be further compromising the LVO obstruction. Okay. So how would you diagnose? How is this condition diagnosed? Echo. And then what is the diagnostic parameter? Yes. Yes, an IVS of more than 6 millimeter. Yes. Okay. So, can you tell, since this baby was having diabetic, this is an infant of diabetic mother, what are the other important cardiovascular associations with GDM? Very good, TGA. Other? Very good, VST. Yes. Okay. So, how would you manage? And what is the natural course of this disease?
Mm.
Very good, beta blockers. Yes. Propranolol. Yes. Would you give inotropes in this condition? No. Yes. And what is the natural history? Yes. So it is basically a self-resoluting condition. So you have to just provide supportive management. If there is LVOT obstruction is causing symptoms, then you can consider for propranolol. So this is asymmetrical septal hypertrophy. Approximately 30 to 40% of infant of diabetic mothers will have this condition. So how does it, it is causing its effect is by causing a dynamic LVOT obstruction, and further worsening the obstruction is basically the anterior motion of the mitral leaflet. It is diagnosed if the interventricular septal thickness is more than 6 millimeter, or the septum to the LV posterior wall ratio is more than 1.3 on echocardiography. Then the next question was, what are the other important cardiovascular conditions associated with infant of diabetic mother? That is TGA, VST, and double outlet right ventricle. So as you all correctly pointed out, that this requires supportive management. Most of these conditions will be resoluting by 1 year. And then in babies who are symptomatic, we will be providing propranolol.
So this is a 28-week preterm neonate on non-invasive ventilation for RDS. He has a PICC line placed over the left great saphenous vein on PND2. On postnatal day 5, he developed sudden desaturation, severe bradycardia that is unresponsive to suctioning and positive pressure ventilation despite good chest rise. The heart sounds were muffled, lung fields were clear. What is the diagnosis? You can see this
This is
echo also. Diagnosis. Tamponade. Okay. What could be the possible reason for this condition? Possible reason. Okay, PICC line. Migrated PICC line. What would be the emergency management in this baby? Emergency management. Pericardiocentesis. Okay. What should be the optimal position of PICC line inserted through upper and lower limb? What's the optimal position?
yes.
Okay. And what are the few complications other than this cardiac tamponade, which you can anticipate in babies with PICC line in situ? Thrombus, effusions, block, infections. Okay, good. So let's
Correct.
go to the answers.
This is
So this is a massive pericardial effusion, as all I think every one of you responded with cardiac tamponade. So here the PICC line have actually migrated. The tip has migrated or maybe malpositioned PICC line into the pericardial cavity. So the management would be emergency pericardiocentesis, and the route will be the substernal approach. Okay. And the optimal position of PICC line, if inserted through the upper limb, would be T4. We never say it like SVC RA junction because that is not visible in the X-ray. You have to tell us the bony landmarks. So for upper limb, it is the T4, and the lower limb, it is T8 to T line. And the possible complications can be catheter migration, malposition, rupture. Sometimes rupture also happen, CLAPSy, occlusions, thrombophlebitis, and the effusions. What many of you have responded. So next question.
okay. So this is an image which we don't normally usually see, but just for the sake, can anybody identify what is the diagnostic modality in this picture below? Not a very usual thing which we see. No, this is actually we should just know this image. This is actually a fetal echo. Okay, so these are the lung fields. This is the four chamber view of the heart. So just nothing detail we need to know about this. We just need to know that there is a diagnostic modality of fetal echo. So come to the next slide.
Yes.
Okay, so fetal echocardiography, it is usually performed between 18 to 22 weeks period of gestation. Important thing to know from our point of view as neonatologist is what are the important indications where we would be performing the echocardiography. So there are fetal related indications, there are certain maternal related indications, and there are indications if there is a positive family history. So if the baby is having a parent or a sibling with a congenital heart disease or with a known genetic disorder which is associated with congenital heart disease, then these babies upfront should be offered a fetal echocardiography at 18 to 22 weeks period of gestation. Or sometimes, if we are having certain anomalies per se in the fetus, most importantly, for example, a fetal height drops, or sometimes the fetal cardiac arrhythmias, you may have persistent bradycardias on their routine antenatal scan, persistent tachycardia, irregular rhythms are arising, or if you have other soft markers which are positive on your antenatal scans, then you would upfront offer these prospective parents fetal echo. And then maternal condition. If the mother is having congenital heart disease, or mother is having gestational diabetes mellitus, or there is exposure to certain teratogens like alcohol, mother is basically a known case of phenylketonuria, mother was on anti-epileptic drugs like valproate, carbamazepine, mother had properly treated treatment for acne using isotretinoin, then had something like a rubella-like infection during her first trimester, then in these conditions, we would be offering these mothers a fetal echo. So important thing to note from this slide are basically the indications for fetal echocardiography.
Okay, next question. This is a 24-year-old full-term male neonate with a birth weight of 3.5 kilo, who is born in a tertiary pediatric hospital. The baby presented with severe respiratory distress, cyanosis, and profound metabolic acidosis despite mechanical ventilation with 100% FiO2 requirement. Chest X-ray is suggestive of bilateral hazy lung fields, and echo is suggestive of dilated RA, RV, and features of pulmonary hypertension with to right to left shunt at the level of AST and turbulent flow at pulmonary at portal vein entry. So this is the X-ray of the baby, and on right hand side, yes.
Echo is properly.
Uh, yeah.
Skip the video. Sorry for that. Yes. The important thing which we'll be noting in this echo will be, so you can see this is basically the right to left shunting, which is happening across the PFO. So
Can
completely
everyone make out this right to left shunt?
we'll be just emphasizing on the important aspects which we can clearly. Other thing which we can see in this is the dilated RA and RB. Third thing we can see is the TR jet. Can you see appreciate the TR jet? And then this is the measurement of your TRZ.
Mm.
Nothing much, very much of significance in this case. Okay, so let's just go on the questions.
Okay. So on X-ray, what you can see make out in the X-ray? So you can see there's a, yes, RDS like picture is there. Plethoric lung fields. There's no cardiomegaly or maybe borderline cardiomegaly with a huge plethora. So next, coming to the questions. So what is the most likely diagnosis? What is the most likely diagnosis? So TAPVC is also of three types. Yes, obstructed TAPVC. Discuss the key X-ray and echo findings that clinches the diagnosis. Echo, Dr. Yusuf has already shown. Na? There's a right to left shunt and there's a TR jet. And X-ray we already discussed. Okay. What are the important cardiovascular conditions associated with this condition?
Because this is just an association, probably heterotaxy syndromes. Yes, heterotaxy.
In condition close, someone is RDS. Okay, definite. What is the definitive treatment? Is there any medical treatment for this condition? We already discussed we don't give PG1 in this condition because that will actually accentuate the pulmonary venous hypertension. So correctly said, this is a case of obstructed TAPVC. And on X-ray, you can see the bilateral hazy lung fields because of pulmonary venous hypertension with either minimal or no cardiomegaly. So there's a light to left center in AST and the dilated RA-RV. Classically, we see in these babies with PPHN. So in babies with PPHN, you should always rule out this infracardiac TAPVC or obstructed TAPVC because it's a very close mimic of PPHN findings in echocardiography. So heterotaxia and asplenia, polysplenia syndromes are associations. And chest X-ray closely mimics RDS and GBS pneumonia, correctly said. And echo finding closely mimics that of PPHN. And PG1 is not recommended in this condition because that actually will lead to increase in the pulmonary venous hypertension and can accentuate the pulmonary edema. So surgical, it's a surgical emergency actually, and you have to reroute the pulmonary veins from the abnormal connection to the left atrium.
So next question is basically a 3 kg baby boy born at term, developed cyanosis within first few hours of life. The SpO2 was 70%. And this oxygen saturation was not improving
Mhm.
and was unresponsive to oxygen. The auscultation revealed a single large S2. The chest X-ray and the echo findings are shown below. So what is this condition diagnosis? What are the important maternal conditions which increases its occurrence? What would be your first line of pharmacotherapy for this condition? And what is the definitive
Mhm.
repair and the timing of repair? Very good. Yes. AJ1. Okay. Arterial switch. When would you perform this arterial switch? Yes. Okay. Correct. So these are basically transposition of gate arteries. Important maternal condition. Basically, gestation diabetes, as we have discussed previously, also increases the risk of TGA. And when these babies are diagnosed upfront, so we can start these babies on intravenous infusion of PGE1. And then if the oxygen saturation is less than 70, when it is started, PGE1 we will not start. Only when the saturation falls below 70 to 75%, or there is presence of lactic acidemia on your blood gases, then you start these babies on PGE1 infusion. And this just acts as a bridge for your definitive surgery of an arterial switch operation, which should be performed as early as possible, preferably between 7 days to 3 weeks, because exposing these babies to increased pulmonary blood flow will increase the risk of hypervengerization. Okay, so it is best done before 3 to 4 weeks of age.
Can you tell what is type of TJ it is? A DTJ, LTJ? Is it a DTJ, LTJ? DTJ, okay. So how did you say? So because the aorta is coming out of the RV and the pulmonary artery is coming out of the LV. You can see
Is
in
this
the echo.
is it a named sign of this echo? Do you know of any sign on this echo?
What is this sign called in echo? Not on X-ray,
Yeah.
on double barrel.
Okay.
Okay. So next
Oh,
question. So this is a term 3 kilo baby boy pregnancy on day 10 of life with a history of poor feeding and lethargy. On examination, he was mottled with poor peripheral pulses. Bilateral femoral pulses were not palpable, and he was hypotensive. 2D echo was done after primary stabilization. This is a 2D echo you can see on the right hand side. This is the arch view you can see. So the questions. So what is the diagnosis? Okay. So what important physical exam finding is to be noted in these babies? Important physical examination finding. Okay. And what is the echo finding? What is the echo finding it is showing? Echo finding.
so echo.
Turbulence. Okay. Okay. And what will be the initial management of this baby? Isthmus narrowing. Okay. What will be the initial management? EG1. And what is the definite treatment? Okay. Correct. Answers, Dr. Ishu. So this is coarctation of aorta. This is correctly said. So important physical finding in this case is the difference in the upper and the lower limb blood pressure. So if you find a difference in the blood pressure of more than 15 mm of Hg, so if you find it, so it rules in coarctation. However, if you are not finding this difference, it does not rule out coarctation of aorta. And you can also find you may also find a low volume or absence of femoral pulses in the physical examination, which should be seen in all babies who are coming to the NICU. So you should always palpate for the femoral pulses in the babies who are being admitted in the NICU or in the delivery room also. So echo findings is rightly said. There's a narrowing of the isthmus and there's a obstructed antegrade flow through the descending aorta. So since it is it's a significant like a severe coarctation of aorta. So after, because the baby is having features of CHF as you have seen. So baby has features of CHF along with the shock. So this is a severe coarctation. So you have to start this after initial stabilization. You have to start these babies on PG1 infusion. They respond pretty well on PG1 infusion. And the definite treatment is like resection of the coarctation segment and primary end-to-end anastomosis in these cases.
This next case is basically a term baby, 3.5 kg, born through meconium strain lichen, did not cry after birth, required intubation and subsequent mechanical ventilation. So this baby had features of moderate encephalopathy. So as per protocol, he was initiated on therapeutic hypothermia. Central lines were placed, supportive care was given. Baby was off ventilation by day 4 and off respiratory support by day 7. On day 11, you notice this baby to have tachypnea. There were mottling. There were signs of poor perfusion. On further evaluation, baby had hepatomegaly, and when you noted the blood pressures were to the tune of 115 over 80 mmHg. The bilateral pulses were well palpable, and then you went ahead and did and saw that there was no difference, as we seen in the previous slide. There was no difference in the upper and the lower limb blood pressures. So we also went ahead and did a KFT and a renal ultrasounds, which are all found to be normal. So what is the diagnosis? How do you, so this is basically hypertension upfront we know, and this
Yes.
hypertension, the baby is in
Yes. Yes.
CHF.
Mhm.
So how do you classify hypertension in neonates?
When do you call it hypertension? How do you define hypertension? Okay. Mild and severe. Hmm.
What are the important things would you do to evaluate, and what could be the possible likely cause in this case?
What is the likely etiology?
AFTs were normal, the ultrasounds were normal. Yes,
Yes.
yes.
And how do you manage this case?
What is the management?
Enoxaparin.
Baby is already in CHF. Why would you give beta? Is this baby having severe hypertension or mild to moderate hypertension? Can you wait for the hypertension to be controlled, or you want the upfront treatment of hypertension? Because that will dictate your management. Yes, so this is severe hypertension because there is immediate management. Why do you say it's severe hypertension? One, because of the BP, and second, because of the end organ being afflicted. So this is severe hypertension. So you need something which should be immediate management. Yes. So there is end organ damage. So what are the important agents would you like to use to control the blood pressures? Drugs to control. Very good. Labetalol, sodium nitroprusside. Yes, correct. So we just go to
Not
the
difedipine, nicardipine. IV nicardipine you can use. Okay.
yes.
And how do you manage? Like, how much blood pressure you want to reduce? You want to. So this baby is having a blood pressure that is above 99 centile, right? So how much you want to reduce? 1/4 first 8 hours. Chalo, Yusuf.
Yes. Okay. So this is a hypertensive emergency or severe neonatal hypertension because, and how do you classify hypertension? So basically BPs which are between 95th to 99 centile, we classify as mild to moderate, and severe hypertension is defined if it is more than 99 centile or if you are having signs of end organ damage. So in this case, the baby was having CHF. The most likely cause and as well as the most common cause for hypertension in neonates is basically renovascular. And since we had a KFT which is abnormal and the KFT which is normal, so most likely would be due to the thrombosis secondary to the umbilical lines which had been placed in this baby. So we would be actively managing the CHF and then active management on lowering the blood pressures with the aim to decrease the mean arterial pressure by around 25% in the first 8 hours, followed by subsequent um, uh, loading.
So,
So yes. So this is the causes of neonatal hypertension. This you can read it from your books. It could be most common cause that we should know of is basically renal, and then there are whole list of other causes also. We should never forget this cause, that is pain, catheterization, are the important causes, and the second important cause that we should be also be ensuring is basically the drugs. What drugs are we giving the baby? Because these are actually common NICU things which happen day in and day out, and this could actually be precipitating hypertension for these neonates. So this is how you manage. So if the baby is having a blood pressure of more than 95th centile, so it could you classify as mild to moderate or severe. Severe if it is more than 99 percentile or there are features of end organ damage. If not, if there are signs, if there is severe hypertension, then you would initiate these babies on IV drugs, which could be the sodium nitroprusside, nicardipine, or labetalol. And then when there is acute control of hypertension has been achieved, then you would be shifting these babies to oral agents, which could be calcium channel blockers, diuretics, etc. And then you would be subsequently monitoring the blood pressures for these babies.
so one thing I want to tell in this management this case. So we all discussed about the reduction of the blood pressure by 25% over 8 hours. So remember that you are not supposed to reduce the blood pressure in this baby below 95th centile before 24 to 48 hours. So you try to reduce the blood pressure below 95th centile over next 24 to 48 hours. You are not supposed to reduce this very rapidly because if you do it, that will lead to cerebral ischemia and can lead to end organ dysfunction as well. So you try to reduce
16.
the blood pressure by 25% over first 8 hours, and then you try to slowly reduce it below 95 centile over next 24 to 48 hours.
The easier question is as image spotter. We have discussed so much echo in the preceding slides. So could you please tell what is image 1 showing, what is image 2 showing, and what are the image 3 showing?
What is image 1? X view, P6 view. Okay.
There is a mode cursor also. What is this? Okay, it's correct. So all of you must be knowing this. So first view is basically apical four-chamber view. Second was the flax view with the M mode cursor. And the third image was the PSAX view. So question 16. So this is a 1-month-old neonate who was admitted with complaints of poor feeding and respiratory distress. On evaluation, we found this baby to be hypotonic and there was generalized areflexia. Lab evaluation revealed elevated creatinine kinase levels. So this is the X-ray, this is the ECG, and this is the echocardiography. Okay, so X-ray. Okay, so what are the three? What do you see in this case, and what is the likely diagnosis?
You already diagnosed it.
Mhm.
Tell the
Yes.
X-ray features, right? And then the ECG and the echo features one by one. Cardiomegaly. What about the ECG? And what about the echo?
Hypertrophic type of cardiomyopathy. Yes. Mm. So X-ray was showing cardiomegaly. ECG was showing signs of left ventricular hypertrophy with large amplitude QRS complexes. Echo was showing LV hypertrophy, thickened IBS, and ventricular hypertrophy. So diagnosis, as you correctly pointed out, is Pompe's disease. What do we do is basically, how do we diagnose this? Absent or markedly reduced levels of acid maltase, and there is enzyme replacement therapy for this condition, which is a recombinant human acid alpha glucosidase. It is alpha glucosidase deficiency, so you provide alpha glucosidase as an enzyme replacement modality.
Okay, so this is a 20-day-old term male neonate who presented with the first episode of brief unresponsiveness with no associated cyanosis, pallor, seizure, fever, lethargy, or feeding difficulty. The baby was born at term gestation by normal vaginal delivery. Birth weight was 2.6 kilo. Baby cried after birth with uneventful antenatal and parental history. The baby was discharged at 24 hours of life. However, on careful evaluation of the history, his elder sibling expired on day 10 of life, and the cause was not known to the parents. On examination, the neonate was hemodynamically stable with normal anthropometry, no dysmorphism, normal systemic examination, normal activity, and neonatal reflexes. The ECG is as shown. Next slide. ECG is not. So you see the ECG of this baby, and you can give the answers. Next question. What is likely diagnosis? Long QT, LQTS. Okay. So how do you calculate the QT? How do you calculate the QTC interval? And what is the value in our case? What is the value in our case? Beginning of Q to end of T. Okay. Well, it is not visible. Okay. Okay, so what are the common condition that can cause a prolongation of QT interval? Common conditions. Hypocalcemia, hypomagnesemia. Okay. Okay. And what are the risks associated with long QT? Azithromycin. Okay. Sudden death.
Any
Okay.
arrhythmias What is the specific arrhythmias associated with long QT? Yes.
Torsades.
Yes.
Any syndrome you know about which is associated with this long QT syndrome? Gerald. Okay. Brugada. It is not Brigada. Brugada. Okay. Gerald Lange. And what is the management? Marvel Lange, Romano word. Okay.
Don't know.
What is the treatment? Treatment. Beta blockers.
Right.
Okay. Go to answers. So this is a long QT syndrome. So how do you measure the QTC? So QTC, so everyone knows QT. So it is QT interval starts from the beginning of the Q wave to the end of T wave. Basically represents the period of ventricular depolarization, repolarization. So how do you calculate the QTC? So QTC is typically recommended to be calculated in lead 2 and lead 5, okay, on the ECG. So you calculate the QT interval and divided by square root of RR of previous RR interval. Okay, so in this case, I don't know whether we can make it out. So there are 9 boxes for QT in interval. So that comes around 9 into 0.04. That will be like 0.36. And there are 11 boxes of RR. So that will be like a square root of 0.44. So we calculate this, it will come as 0.52 second. So any value in a newborn in the which is above zero point 0.5 is actually abnormal. So before labeling it as a familial congenital long QT syndrome, you should rule out some electrolyte disturbances like hypocalcemia and hypomagnesemia, because that can also lead to prolongation of QT. And as has been said, torsades de pointes is the most common risk associated with this long QT prolongations, and it can actually lead to sudden cardiac death. Sometimes the baby can come to you with seizures also. Okay, and the syndromes associated are Romano Ward syndrome. This isolated cardiac manifestations, the most common one. Then Jervell and Lange-Nielsen syndrome, which associated with congenital deafness also. Then Timothy syndrome, and the management of this condition is to give oral propranolol, because because that is a drug of choice in this condition. So genetic
So this
testing
is
is important. So all first relative of these cases should be tested for long QTC using ECG, and if the index case is also positive, genetic index case is positive for genetic mutation, then the first relatives should also undergo genetic testing to rule out long QT syndrome. Next question.
so this is actually an image spotter. So what is the probable diagnosis? Can you interpret the ECG?
Which type of heart block? You also write that.
Which type? Complete heart block.
Hmm.
Carefully look at lead 2.
Hmm.
So basically, you can easily see that there's a P wave followed by QRS, P, there's no QRS here, then P, QRS, P, QRS, P, QRS, P, no QRS. Most likely here, what is the difference between type 2 and type 2B, which you are mentioning? Is there a difference? Yes. So in this case, what appears to be the PR interval appears to be constant. Okay, so type 1, what is associated, what is type 1? What is Wenckebach phenomenon? Yes, yes. Okay. So, what investigation would you do to confirm the diagnosis? And how is it contributing to the underlying pathogenesis of the disease? Very good. Okay, very good. Anti-ROLA. Okay. Mother may you may screen for ANA and DSTN. And what are the indications for permanent pacemaker implantation in neonate? A little more specific, can we be? Okay, so just to go to the answer, yes, 55 it is right. Okay, okay. So as you all, this is a congenital heart block type 2. Uh, so this is the diagnosis is neonatal lupus. So we will be screening for anti-Ro and anti-La antibodies. And how does it happen is basically these anti-Ro and anti-La antibodies, they will actually mimic uh, the AV nodal structures. So they will actually go and destroy these AV nodal structures, leading to fibrosis and progressive destructive process. And the indications for permanent pacemaker implantation is a congenital third degree heart block with a ventricle rate of more than 55, or if there is an underlying CHT, a ventricle rate of less than 70. And if it is associated, if this congenital third degree heart block is associated with an escape rhythm, complex ventricular ectopy, or dysfunction, then you have to put in a permanent pacemaker in these babies.
Okay, so importantly, you have to understand that this CHB is actually progressive. So it's like here you can see that the baby is having CHB type 2. So it can progress to type 3 or complete heart block also. And these heart blocks are actually permanent. This is not temporary. They will not respond to the treatment. It is a permanent heart block. And many of these babies might require pacemaker implantation based upon the criteria for implantation as has been enumerated in the slide. Next question, Yusuf.
Okay, so diagnosis. First, describe the ECG. On the basis of that, you can diagnose this condition. Describe the ECG. Okay, so this is basically PSVT. How do you describe? Very good. Yes, yes. So basically in the CCG, what we see is one thing upfront we can see is basically there is tachycardia. Second important thing we can see is basically the QRS complexes are narrow. So we come into the limb of narrow complex QRS tachycardia. Then we are not able to discern the P waves. We can't discern the P waves. So this is basically a narrow complex supraventricular tachycardia. So what are types of PSVT? Types of PSVT? Okay. Yes. AV nodal reentry and AVRT. Okay. Which is more common, AVRT or AV nodal reentry tachycardia? Very good, AVRT. Are there types of AVRT?
Mm.
Antidromic and orthodromic. Okay. And among the antidromic and orthodromic AVRT, which is more common? Orthodromic, correct. Okay. So, what is the drug of choice for this condition? Correct, adenosine. So, if this baby is having signs of hemodynamic compromise, would your management change or will it remain the same? Very good. So you would do a DC cardioversion for this condition. Okay. What are the other drugs? For example, this baby is having PSVT, not responded to adenosine. Okay, but still hemodynamically stable. You want to try for more drugs. Okay, amiodarone. Other drugs? Any beta blocker agent? Esmolol, correct. Okay. So what is the long term? What is the natural history of this condition? What are the indications and the choice of drug would you give for long-term therapy? When would it resolute? And what is the drug of choice? Yes, usually by year, most of these conditions will resolute. Yes, the most commonly drug which is implicated is propranolol.
Mm.
Okay, let's go to the answers now. So So this is a paroxysmal supraventricular tachycardia. We'll not go into the depth of basically this is how
Mm.
a SVT, supraventricular tachycardia is classified, whether it is a reentrant type or an automatic type or a triggered type. But just let's focus on the reentrant type. The most common which we are focused on are the AVRTs and the AVNRTs. So what were the important findings in our ECGs? Sorry. So we had tachycardias. The QRSS complexes were narrow and they were uniform. We could not discern the P waves. And there was no beat to beat variability. It was a highly regular rhythm. So this is clinches our diagnosis of PSVT. And as you all correctly said, that the drug of choice for this condition is adenosine. So how do we manage? So basically, if a baby is having SPT, we see for hemodynamic stability, and then there is something which is mentioned as vagal maneuver. What is this vagal maneuver? Which vagal maneuver can be done in the neonate? Can you do a carotid massage or in this baby? Yes,
Ice pack. Mm.
yes. How would that act? How would an ice pack act? What is the limb? What is the afferent nerve which will get stimulated? So then the efferent will be vagus. So it is basically trigeminal-vagal activation. Yes. Okay. So we can do a vagal maneuver that is mainly placing an ice pack or starting these babies on IV adenosine. If it is non-responsive, then the next agent which we can use is basically esmolol, and then we can use, if that is also not responsive, then amiodarone. If the baby is hemodynamically unstable, then we can just give a shot of adenosine and then cardiovert these babies. So this is the drugs which we have already discussed. So indications for long-term therapy. So indications for long-term therapy would be if it was a hemodynamically significant supraventricular tachycardia, or and if or there are SVT is frequent and it is requiring medical management, or there are associated underlying congenital cardiac defect. There's something mentioned as a pre-excitation. What do you mean by pre-excitation on ECG? Sorry. What do you mean by pre-excitation on ECG? Can you name some syndrome? Yes, very good. What WPW? Yes. So is it when this premature excitation can be seen in antidromic type or a orthodromic type of AVRT? No, this is seen in case of antidromic AVRT. Yes, it is seen in case of antidromic AVRT. The choice of drug is propranolol, which is most commonly used. Other drugs can be used are flecainide and amiodarone. And mostly 70% of these neonates will lose their inducibility by a year. So what those the cardiologists will usually treat them for 6 to 9 months and then continue the same dose. So as the baby will grow, he will outgrow the drug doses. So by 1 year, most of these babies will not require any medications.
Okay, so next question. So you can see the drug on right hand side, the image. What is the indication of using this drug? PSVT already discussed. What is the dose and mode of administration? Dose and mode of administration. Okay. What is the half-life of the drug and the time of onset of action? What is the mechanism of action of this drug? Okay, and what is the side effect? Okay, let us see the answers. So this drug is used for management of supraventricular tachycardia. The typical dose is 0.05 mg per kg. So you give a 0.05 mg per kg as initial dose, and then you increase every 1 to 2 minutes based upon response to up to maximum of 0.2 mg per kg. Remember that this drug has to be given through a rapid IV bolus, and that is followed by saline flush. And preferably the IV route should be the one that should be placed close to the heart. It means you have to give this drug through the UVC or through the PICC line so that it directly goes into the heart without getting metabolized. It is because of the fact that the drug has got a very short half-life of 10 to 50 seconds only. So if you give through the cannula, the drug actually may get metabolized. And the onset of efficacy typically starts quickly within 10 to 20 seconds of administration. The mechanism of action is that adenosine acts to the adenosine receptor, which are there in the AV node, and then it leads to blockage of the AV node conduction by increasing the potassium efflux and decreasing the calcium influx, thereby blocking the AV conduction. And the side effect of this drug is like flushing, bronchospasm, transient new arrhythmias, rhythms can be seen at the time of conversion. By that also, it can also be used for diagnosis of the arrhythmias. That includes PVCs and PATs. It can also lead to sinus bradycardia because of the mechanism of action, and tachycardia, as well as varying degree of AV nodal block. So if the baby does not respond to this adenosine infusion, and the baby goes into hypotension or hemodynamic instability, you can consider to give DC synchronized DC cardioversion, starting with 0.5 joules per kg and then increasing to 2 joules per kg.
So just you have to name the common cardiac effects associated with these genetic disorders. So what is seen in case of trisomy 18?
Commonest cardiac defect in trisomy 18.
Okay. Okay, in 21, endocardial cushion defect. Very good. Okay. What is seen in case of a Turner syndrome? Very good. Coarctation. Any specific bicuspid aortic valve? Very good. What is seen in case of a Noonan syndrome? Coronary stenosis. Nice. What are the anomalies which is seen in case of George? No. Peripheral PS is not seen. Conotruncal, yes. Yes, conotruncal. And then Chart syndrome? Very good. If I ask about what you see in case of Williams syndrome? What type of AS can be seen in Williams syndrome? Supravalvular, yes. And what is the cardiac anomaly, let's say, you see in case of Alagille?
Yes.
Peripheral branch PS, yes, correct. So all of you correctly pointed out the answers. So basically, in trisomy 18 is basically VST. Trisomy 21, we see a common AV canal defect. In Turner syndrome, bicuspid aortic valve as well as coarctation of aorta. In Noonan syndrome, we see pulmonary valve stenosis. George and Charge, both of them are more or less associated with chronotruncal anomalies. Question 22. What is this? What is this image showing? One which is highlighted. IV. Sorry. Okay, it is showing the IBP monitoring. What are the common sites which you use the IBP monitoring for? And how would you ensure that your measurements are optimal? And could you please describe the waveforms? How do you describe these waveforms? UAC, radial, posterior tibial. Okay. Okay. What are the various waveforms seen in this case? In any arterial BP?
Waveforms.
Waveforms.
Okay, complications.
Complications. What are the important complications? And how would you say that this baby is having hypertension or this baby is having hypertension? What are the important charts that you use as normograms, as reference normograms? Okay, complications are correct. Yes. Other charts did you know of apart from Zubro? Very good. Zubro, Diniz, McNamara. Very good. Okay, so we'll go and see the answers. Okay, so this is an invasive blood pressure monitoring. As you all rightly pointed out, we can do this using umbilical artery, radial artery, or a posterior tibial artery. Important thing to be sure of is that you do zeroing when you are starting the ABP monitoring or whenever there is a position change in this baby, and then the transducer should always be at the level of heart. And what is the most common? Sometimes you will have abnormal readings or you will have dampening of your waveforms. The important thing is to ensure that there is no air bubble in your line circuit. And then this is the common waveforms which you see. There is a rapid systolic upstroke, then there is rapid systolic upstroke, then there is a systolic peak, then there is a dicrotic notch, and then there is a diastolic runoff phase. So that what is this dicrotic notch is suggestive of the point where aortic valve actually closes down.
Closes.
Okay. Then thromboembolism, vasospasm, thrombosis, infections are the common complications associated with any arterial line. And then, what is the important test that you must perform when you are doing a radial artery puncture? Allen's test. Yes. And for example, when you put in a UAC line, one limb has gauze blanched. So what you would do? Immediate next step, warm in the contralateral. Yes, correct. Okay. So then the important charts are basically the Zubro's charts, the Dini's chart, and the McNamara's chart. Okay.
Okay. So you can see a monitor on the left hand side, and the baby is being attached to that monitor. So what is this imaging showing? NIRS. What is the principle? BL limit. What is the possible site that can be monitored? Possible sites that can be monitored. One you can see in the image also. Head, abdomen. Okay, cerebral mesentery. Correct. So what is FTOE? What is this term FTOE? Expand FTOE. Okay, so some important trials that studied in this technology. Fraction tissue oxygen. Okay, so do you know any trial that has studied this technology in newborn? Say pussy. Okay, let's go to answers. So this is NIRS. So basically, it works on the principle of Beer-Lambert law, which we already discussed in the first question. So most common site of monitoring is the cerebral, that is forehead, where it monitors the brain tissue oxygen uptake. And you can also use it to see for the renal perfusion by placing the probes over the flank areas, and you can also monitor the gut oxygenation, perfusion and oxygenation by placing the probes over the splanchnic area in the infraumbilical or in the lower abdomen. So next question, next slide. So F2 stands for fractional tissue oxygen extraction. So basically, in NIRS, it basically measures the oxygen uptake in the tissue and how it is measured. So this is measured by this method, that is FTOE. So here it reflects the balance between the oxygen that is delivered to the tissue and the oxygen that is consumed by the tissue. So suppose if the FTOE comes high, so that suggests there is an increased extraction of the oxygen. So that can occur because of two reasons. So first thing is that it can be because of shock, reduced perfusion, so more oxygen is required, or it is because of increased metabolic demand, like in babies with parental asphyxia, where the brain cells are more metabolically active in the penumbra region. So in those cases also your FTE may increase. The trial that has been used that has actually used NIRS principle for use in neonatology is the SAFE-BUSI trial. So SAFE-BUSI 2 trial demonstrated that NIRS guided management is significantly reduces the risk of cerebral hypoxia burden in extreme preterm infants. And SAFE-BUSI 3, which is a recent one, it's a large RCT where it is found there is no significant reduction in the clinical outcomes of death or severe brain injury with routine NIRS using in extreme preterm newborn. Others are like Osgood trial and NINO study. NINO study was done basically to assess for the risk of NEC, predicting the risk of NEC using NIRS.
We come to the last question of our discussion today. So this is a 25-week, 820 gram preterm neonate on day 4 of life develops hypotension, tachycardia, blood gases shows rising lactate levels, is passing less urine, and on invasive blood pressure monitoring, you found the blood pressure to be 42/18. On clinical examination, the pulses are bounding. His FiO2 requirements have skyrocketed overnight. You did an echo. Echo was showing a large pulsatile left to right shunt hemodynamically significant duct with a LAO ratio of 1.8. LV functions were towards the lower side and the SVC flow was reduced. Okay. So this baby is having shock. So the question is, what are the various pathophysiological processes are operating in this baby which is contributing to the shock?
Pathophysiological process. Ductal
Because
steal.
that will actually help in choosing your choice of inotropy.
Yes.
Ductal scale. Okay. Okay. Correct. Okay. Fine. So I mentioned in this echo that we started measuring SVC flow. So is there a relevance of SVC flow measurement when you are doing a focus for a neonate? And how do you define an low SVC flow? Why are we so much focused on SVC flow? Yes. Okay. So yes, you define low SVC flow as 40 ml per kg per minute. So as you know, in units, they are having shunts. These shunts are at the level of PFO. They are at the level of basically PDA. So you can the LVO, that is left ventricular output, and right ventricular output cannot be determined nicely. So the systemic flow can easily be assessed using SVC. So this SVC and further SVC, the low SVC flow has been associated with low IBH and adverse neurodevelopmental outcome also. So this actually shows that SVC flow measurement is of paramount importance when you are doing a focus for a baby in shock. Okay. So important thing, we have discussed the pathophysiology. Okay. So how would you manage and how would you choose your inotropes in this baby? Discuss in the light of your recently published NNF shock CPG guidelines.
No, we're talking about the inotrop.
Inotropes. Yes, you would like to give a fluid bolus, correct? Adenosine, why would you give adenosine in this case? Okay. Okay. So we'll just have a discussion. So choice of inotropes is we'll discuss in the subsequent slide. What is the dose of hydrocortisone and when do you give hydrocortisone? Baby is already having oliguria, so we'll be slightly wary of when starting vasopressin first hand. Okay. What is the dose of hydrocortisone?
This is a preterm baby.
Okay, correct.
Take, I'll go to the
We'll just
answers.
discuss the answers. So, the pathophysiology which is occurring in this baby is basically a systemic steal secondary to a large PDA, which is causing a diastolic runoff. There is pulmonary overcirculation, which is contributing to the high FiO2 requirement. And at the same time, the SVR is also low, probably sepsis is underlying. Then this is a preterm baby who will have an immature myocardium, will have a limited reserve. And secondary, LBWs are also predisposed to having adrenal insufficiency. So whole almost all types of shock, all types of shock is playing out in this baby. So as you all correctly pointed out, low SPC flow is defined as less than 40 ml per kg per minute, and it is a true marker of your systemic output because it is not shunt dependent. And in studies, it has been shown to predict with IBH as well as poor neurodevelopmental outcome. Okay. Then coming on to, so how would you manage? So we will consider a fluid bolus, and the first line vasoactive medication we will be using is basically dopamine. Why dopamine?
Why dopamine? So dopamine is basically a non-selective pulmonary vasoconstrictor. So that will lead to increase in the SVR as well as PVR. So by increasing the PVR, it will actually reduce the amount of left to right shunt. And by increasing the SVR and cardiac contractility, it will increase the blood pressure. So that's the reason that dopamine is considered as an inotrope of choice in babies with PDA.
And hydrocortisone, since this was a preterm baby, we gave a dose of 1 mg per kg followed by 0.5 to 1 mg per kg every 8 to 12 hourly for a total of 2 to 3 days. And in a term baby, slightly higher doses. Okay. So this is just a brief highlight of your NNS CPG guidelines. What are the choice of inotropes? They have given us a choice of inotropes in various types of shock. So if there is a transitional shock in the preterm in the first 24 hours, they consider the choice of inotrope to be epinephrine. In PDA, we have discussed now only that it is dopamine. For asphyxia, it is dobutamine, and in a septic neonate, it is epinephrine.
So would like to hand over the stage to Dr. Sushant.
This shock